Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today in the Conversations with Cancer Experts series, we have Dr. Deborah Stephens, who's Associate Professor of Medicine. She's Director of the CLL and Richter's program in the Division of Hematology at a premier university, University of North Carolina, and we're thrilled to have her today. Welcome, Deborah.
Yeah, thanks for the invitation.
We're going to talk today about chronic lymphocytic leukemia and outcomes in high-risk disease. So before we get into the discussion, how do you define high-risk disease?
And this is a great question, and I really evolving. You've listed a few things that are really important. I mean, we have both clinical and molecular risk factors that we look at, and I think a key thing is checking these at diagnosis because these both help us to figure out if we can best advise the patients. Are they somebody who's going to need treatment very quickly with CLL, or are they potentially going to be somebody who could go the rest of their life without needing a treatment? And so I think some people say, well, if we're not doing treatment up front, why would we even check these? But I think it's actually pretty helpful to patients to give an idea of their outlook. When somebody comes in, I certainly do their initial staging. This is all done by clinical exam and labs, and so we don't need to do imaging or bone marrow biopsy or anything to do this. In the United States, I use the RIE staging, and this is really just to give kind of a general idea because the diagnosis point of CLL is a little bit ambiguous because I mean, a lot of times you look back at their labs and you think, gosh, they've probably had CLL for 2 years or something. So the date of diagnosis is a little bit ambiguous, but when they come to you and it's their first diagnosis, that's when I assign their clinical staging. Staging goes from 0 to 4. 0 is just a high white blood cell count, going to 1 with enlarged lymph nodes, 2 with a big spleen or liver, 3 with anemia, or 4 with thrombocytopenia. And so most people want to know their stage when they're diagnosed. I usually, talk with them about CLL and say, there's a lot of labs that we can do to understand your risk factors. And so I generally will do a CLL FISH panel, and that would include looking for deletion 17p, deletion 11q, trisomy 12, and deletion 13q. I also like to include in this just a translocation 1114 because that being negative really definitively rules out that this is a misdiagnosed mantle cell lymphoma. And so I usually include that in the CLL FISH panel. And then the IGHV status, you're going to determine whether they're mutated or unmutated, and then TP53 status, mutated versus unmutated. What I do with these is I put them together and I actually generally will calculate something called a CLL International Prognostic Index, and it uses a lot of these factors. In this, the highest risk or the highest point value is if you either have a deletion 17p in the FISH, or if you have a TP53 mutation. And if you have either one of those, you get a score of 4. And so that's a high risk. The next thing that I look at is the IGHV. If it is unmutated, risk, and so you get a score of 2 for that. I also check something called a beta-2 microglobulin, which is used in a lot of different heme malignancies. It's really a general marker of inflammation. But if that is elevated over 3.5, you also get 2 points. And then your RIE stage, if you're anything above 0, you get 1. And your age, if you're anything above 65, you get 1. And so you put all those together, and there's a total possible score of 10 points. Anything that is 4 or higher is considered high-risk disease. Why I like to use that? Because it's been a validated model for overall survival. So higher your risk score, the shorter your overall survival. And I really like it because you can use it to predict time to first treatment. And so the higher your risk score, the shorter your time to first treatment. And so I think patients like to wrap their mind around this because, you're diagnosing them with a cancer and then most of the time saying, hey, we're going to observe you and see how things go. I think they like to have something a little bit more concrete in their hands to say, yeah, I've got these high risk features and I really should be planning planning for treatment here in the coming years. I think the most important factors are IGHV status, and that is because at diagnosis, I think almost every single person with unmutated IGHV is going to need treatment at some point. It's a higher proliferating CLL, so most likely they're going to need treatment, and I tell people this. The mutated copy is actually the better copy of IGHV, and there are quite a big population of these patients that may not ever need treatment. And so I think that's a really good starting point to say, hey, this is what we're looking at in the future. And then I think the next most important factor is either TP53 mutation or deletion 17p. A lot of people use these interchangeable, but they're not the same thing. And so, they both have pretty similar meanings, but not every patient will have both a TP53 mutation and a deletion 17p. And so, that's why I specifically check for both of those things, because they're not the same in each patient.
So
These are important because they generally have shorter times to first treatment. And when we do a treatment, we need to know that, because we want to select the treatment that's going to have the best chance of the longest remission, because this is probably the factor that is most predictive of time to response.
So, how many percentage of patients have the IGHV and the TP53 mutation? And
Yeah, great question. The IGHV is about 50-50. So about half the patients are going to have a mutated copy and half are going to have an unmutated. The TP53 and deletion 17p, it depends on where you're at in treatment. So right up front, at the initial diagnosis, there's only about 10% of people that are going to have a TP53 mutation. But once you get into the relapse state, it's much more common. And some of it depends on what kind of treatment they got as their initial treatment. Rates were quoted, up to 25% in people who got chemoimmunotherapy like fludarabine or bendamustine, whereas it's a little bit lower in folks who have gotten some of the targeted agents like BTK inhibitors or venetoclax in the second line setting. And so, I really like to kind of put all this information together. I usually do an initial consultation about, hey, this is CLL, this is what it is. Then I'll bring them back and I'll talk about their specific risk factors once I have them. I think right now, especially in the United States, this is important because there's a large study which I chair through the SWOG cooperative group called the S1925 Evolve study. And so patients with a CLL IPI of 4 or higher, or a complex karyotype, which we define as people have 3 or more abnormalities on their karyotype, they would be a candidate for this early intervention study. And basically, we're using some of the new therapies, venetoclax and obinutuzumab, as an early intervention strategy for high-risk patients. And so not only are you kind of giving people an idea, if you have a high-risk patient, you have an opportunity to offer them this clinical trial, which is open across the United States and Canada.
now, for off study, high risk doesn't mean that you definitely need to treat at the time of diagnosis.
Exactly. I use that more so just for planning for future purposes and so I can advise the patients what to expect.
What percentage of patients with CLL that you observe ultimately need treatment?
That's a great question, and it kind of evolves all the time. And that would probably be dependent on each physician too, because, the criteria to treat CLL are stated, but they're not always followed exactly to the T. And so, and I probably have a little bit more biased view because I'm at a tertiary referral center. And so a lot of times high risk patients will get referred to me. And so I would say there's probably a population of about somewhere between 20 to 30% of people that are never going to need treatment. But again, something might come up that changes that. And so, depending on what treatment center you are speaking of, I have a primary, my only patient population are CLL folks in a tertiary referral center. So
Sure.
a majority of my patients are going to need treatment but that's maybe because they were referred to me specifically for that reason. They're higher risk.
So what's the average time for a person who's under observation in treatment, and then what is the average time for a high-risk patient?
Good question. So in a high-risk patient, so again, kind of using the CLL IPI score, the median is about 3 years to treatment. And the lower risk, there's, very low risk, intermediate risk. Those patients could be, somewhere between 8 and 10 years. But again, as things kind of change and treatments get better and less toxic, I think people are a little bit less hesitant to start treatment. And so, I think in general, it's possible people get treated a little bit earlier just because we have good treatments to offer.
Sure. And so putting it in historical perspective and then coming to the present era, what do we know from the era of chemoimmunotherapy and the implications of the high-risk features?
Yeah, great question. As I mentioned, kind of depending on what initial treatment you get, will depend on how high of risk your disease is when it comes back. And what we know certainly is that it's very high risk for people treated with fludarabine, which you can see that's like the fourth column there, or bendamustine in the frontline therapy. They're much more likely to have high risk disease, and that includes TP53 mutations. And complex karyotype when the disease comes back. And so thankfully, majority in the United States have kind of moved away from using those agents, and so hopefully we'll see over time that can kind of cut down on the number of refractory CLL we see with these high risk mutations. But I do realize that there's lots of countries that don't always have an option to do the novel therapeutic agents, and so these are still great treatment options, but it is we do know that they come back higher risk disease when the disease comes back.
So moving on to the current era, let's start out with BTK inhibitors and the implications of having high-risk disease. So obviously the first BTK inhibitor was
Mm-hmm.
ibrutinib. And
Mm-hmm.
could you tell us about what one should expect with high-risk patients with ibrutinib?
Yeah, absolutely. I think one question that I get asked a lot is, let's say you have this newly diagnosed patient with TP53 mutation or deletion 17p. What do you do? What treatment do you recommend? Would you go more in the line of BTK inhibitors, ibrutinib, acalabrutinib, zanubrutinib, or would you go more in the line of venetoclax and obinutuzumab, which are two kind of routes of our best treatment options currently available in the United States? And when I answer this question, I'm answering it with not full data, and I hope we'll have some of this data. And what I mean by that is there's not really any available comparison directly head to head between BTK inhibitors and venetoclax and obinutuzumab in frontline. And so we kind of do these imperfect comparisons looking at similar trials. So a frontline trial with a BTK inhibitor, a frontline trial with venetoclax and obinutuzumab. And we kind of try to piece together, well, how well do people do? So maybe do we get the idea which class is better? And there's several caveats to this. So I generally, at least at this time, it seems to me that BTK inhibitors will lead to longer remissions in the TP53 and deletion 17p CLL patients. And that's based on some of the studies that you're showing. And maybe we can go through the slides here. You can see first off is ibrutinib, and you can see out at 6 years, there's a 61% PFS. At 3 years, there's an 85% PFS. And if you want to go to the next slide, these are the data in frontline patients with acalabrutinib, another covalent BTK inhibitor. And the two curves up top are the curves that include acalabrutinib. These are specifically patients with deletion 17p or mutated TP53. And just note that this study was not specifically done in this population. You can see down at the bottom there, it's smaller patient numbers. So we're looking really at, 23 to 25 patients in each category. The other comment I'll make on this before we move to the next slide is those top two, they're either acalabrutinib or acalabrutinib plus obinutuzumab, which is a CD20 antibody. And so often I think people have a knee jerk, well, it's a higher risk. We should maybe do more therapy and they'd be more likely to do better. But this shows that either using the CD20 or not using it has almost exactly the same PFS. And so I generally don't like knee jerk to add a CD20 antibody to these BTK inhibitors. And you can see again, 3-year PFS as compared to that ibrutinib curve, it's right around 80-85%, similar to what we saw with ibrutinib. And then if you go to the next slide, this is zanubrutinib, the other available covalent BTK inhibitor. And this study was specifically a cohort of patients with deletion 17p. And you can see again, kind of similar that the 3-year PFS rates are around 85%. So all really good compared to what we used to see with chemoimmunotherapy. I mean, that was where, a lot of times you would see younger patients with TP53 just referred to allogeneic transplant right away when we didn't have any of these novel agents. And of course, a lot of folks with CLL are older and they're not a candidate for transplant. And so, these treatments came along and really changed the field of CLL. And I mean, I just think BTK inhibitors are a great option for patients with high-risk disease. If you want to go to the next slide, this is where you kind of see that there is a difference in the numbers that we see with venetoclax and obinutuzumab. And I want to just really start by pointing out that there's a really key difference between BTK inhibitors and venetoclax and obinutuzumab. And that is that in the frontline setting here, the CLL-14 study, venetoclax and obinutuzumab was only given for a year. And so you give it for a year and then you stop therapy. And so BTK inhibitors, they're given continuously. And so, some of the critique between like making the decision between venetoclax and obinutuzumab or BTK inhibitors, it's like we're actually comparing time-limited venetoclax versus forever BTK inhibitors. And so what if we gave venetoclax forever? Would we actually see some similar results? Whereas if you see on these graphics, over on the left-hand side, the progression-free survival by TP53, and I'm looking specifically at the blue curves, because those are the venetoclax and obinutuzumab patients. You can see the dotted line, which is the best PFS, are the patients who did not have TP53 deletion. And you compare that to the solid blue line, which are the patients that do have TP53 mutation. So if we're thinking about continuous therapy, they would be getting continuous venetoclax for the first 12 months. And if you look at the first 12 months, there is a separation in the curve there, but it's not quite as dramatic as it is out at later dates. And so maybe a better comparison would be, continuous venetoclax therapy, or what happens if you do venetoclax therapy, you stop for a while and then you retreat, like 2 courses of venetoclax therapy. Would that be equal to 1 of BTK? We don't know the answer to that yet, but there's a large study going on through the German CLL study group, which is called the CLL-17 study, which actually does compare continuous ibrutinib to venetoclax and obinutuzumab, and actually time-limited ibrutinib and venetoclax. So I think we'll have a lot of information about that. That study is not specifically for patients with high-risk disease, but it will certainly include some patients, and so we'll get a look at that. But, if you look at this just, flat out, the data show that patients with deletion 17p don't do as well as the patients without it with venetoclax and obinutuzumab. And so that's where a lot of the recommendations that physicians give to give BTK inhibitors to these patients come from. And, the next slide here, it looks.
I'm sorry, going back and forth. Were you done with this slide?
Actually, maybe we can stay with this. The other thing that you'll notice here is the IGHV status, because there's also some question about if you have an unmutated IGHV, is a BTK inhibitor better? And again, there's just a little caution that I give that a lot of times, if you look at, there's a lot of overlap between unmutated IGHV and TP53 mutation. I think at the EHA 2024, I think it was the German CLL group put out, their follow-up of like 10,000 patients and, patients with TP53 mutations. And those people who had TP53 mutations, there were like 75% of those had an unmutated IgHV. So there's some overlap. So these are not like mutually exclusive populations. So there is some overlap there. And then again, if you look at that first 12 months of the curves are exactly the same in the blue arm. And so, again, we're looking at continuous versus, only a year of fixed therapy. And so again, I think the direct comparison will be helpful because if you just look at it this way, it looks like venetoclax and obinutuzumab, the patients with unmutated IgHV are not going to do as well. And then if you go to the next one, actually skip to the next slide. Because when you look at these are kind of similar trials using a BTK inhibitor or venetoclax and rituximab in the relapse setting, just saying, do we see the same things in the relapse setting? And if you look at the BTK arms, the mutated and unmutated completely overlap. Whereas the venetoclax and rituximab, again, you see these, the unmutated IgHV having a shorter progression-free survival. But again, in the second line setting, in this Murano study, they were given a time-limited course of 24 months. And so at 24 months, the curves are actually still pretty similar. And then as you get further out, you see the separation. So again, unclear. And if you want to go back to the last slide, because this shows in the relapse setting, this shows the kind of two different studies that look at either ibrutinib or venetoclax and rituximab, and it shows similar to what we saw in the frontline setting. Whereas, in the TP53 mutated patients, BTK inhibitors still do really pretty good, whether or not you have the TP53 mutation or not. Whereas in the Murano study with venetoclax and rituximab, looking at the blue curves, you do see a shorter PFS in the patients with TP53 mutation again. And so, again, they're not perfect comparisons, but these are where kind of the recommendations of most experts to give a BTK inhibitor for these high-risk patients. But is it wrong to give venetoclax-based therapy? Absolutely not. I think we don't know enough about, retreatment and, what happens if you just give the drug continuously, if that would help. So I think the jury's still out a little bit, but I think majority of people would recommend BTK inhibitors here.
So obviously, we're moving into an era where it may not be either or, it may be all of them at the same time. So what do we know about high-risk disease and combination with both BTK and BCL2 inhibitors?
Yeah, great question. And there are so many clinical trials out there right now with some variation of, one of the BTK inhibitors plus venetoclax or another novel BCL2 inhibitor, and then plus or minus obinutuzumab. And so there's so many combinations out there. I will say the majority of studies, they just include all comers. And so, they would give us some information about, usually about 10% of those patients are going to be deletion 17p or TP53 mutations. I like this study specifically because these are patients specifically with deletion 17p or TP53, so it gives us a look at that. Just commenting about the choice of regimen, again, there's a little bit of data from other things that maybe obinutuzumab doesn't make that big of a difference in deletion 17p or TP53. So is it really necessary in this regimen, or is just a two-drug combination of a BTK inhibitor, BCL2 enough so that you kind of eliminate any toxicities that you could see with obinutuzumab? Again, that's kind of thoughts possible that we don't really know fully the answers to this. But if you go to the next slide, the responses are quite good. The overall response rate is 100%, which is incredible. And if you just give a BTK inhibitor, the CR rate would be a lot less. And so definitely the venetoclax and the obinutuzumab help us get more complete remissions. And then you can see the difference in undetectable MRD status. And just keep in mind that those green boxes are patients that are missing information. And so, just keep that in mind as you look at the numbers of patients that achieve each here. But you can see that even despite that, there are some patients that are missing. You can see at cycle 15, 65% have undetectable MRD status, which is great. But you can already see at 3 years where patients start to lose that response. And so, it just shows us that our regimens to date still are not curative of CLL. We're still trying to figure out how do we get people into the deepest remission possible. Does it make sense to give people treatment breaks? And so we can, stop therapy and then restart with the same therapy if there's no resistance mutations. I think there's still a lot to be known about, does it make the most sense to, like, for example, start with a BTK inhibitor, go to a BCL2 inhibitor regimen when they relapse, or vice versa? Or does it make the most sense to give them both up front? If they relapse, give them both again, and so there's still a lot to be figured out about, the sequential versus like combination therapies, and, always taking into consideration that the average age of diagnosis of CLL is 72. And so, some of these combination therapies, they definitely have more toxicity. And so, I guess I'll give an extreme example. Let's say you have a patient who's 90 years old and they need CLL treatment. Does it make sense to like hammer them with 2 treatments and cause toxicity? Or does it make more sense just to give them the least toxic treatment possible, get them as many years as possible and then reconsider? Whereas, that's a different patient than like a 35-year-old patient that needs treatment. You have to think of a lot more years of where you're trying to keep this person alive. And so I just think there's still a lot we need to learn. And, there's a lot of good clinical trials that are going on right now will help answer some of these questions.
So obviously, till we have those trials, and there will be more questions when those trials are reported out. How do you approach your high-risk patients? I'm sure there's not one strategy that fits all, but just broadly, what is your approach to the high-risk patient?
Yeah, great question. So outside of a clinical trial, if a patient and I consider the highest risk to be TP53 or deletion 17p, I would generally give them a BTK inhibitor therapy. I'm choosing between acalabrutinib and zanubrutinib because they have the best toxicity data. And right at this given time, zanubrutinib actually has the most data for TP53 mutated patients in the frontline setting because they did that specific Sequoia study. And so that would probably be my recommendation, is doing zanubrutinib in that setting. If I have the option to do a clinical trial, I always will with these patients because I don't think we have the right answer. So for example, right now, we have a clinical trial comparing venetoclax and obinutuzumab versus a BTK inhibitor and BCL2 inhibitor combination. And I still think, it would be the right answer to even enroll a high-risk patient on that because is this combination better? Now we have data that we can retreat with venetoclax and obinutuzumab. And so, again, I think it kind of depends on what's available at the time and the patient. And, if they're motivated to go on a clinical trial, I would send them there because, we just need to know the answers for this patient population, and we won't know that without putting them on trials.
I wish to thank you very much for that educative session. Best of luck for the trial that you're leading, and I hope that I can return to you as we have some of these answers in the future and some more questions, I'm sure, as well.
Yeah, thanks again so much for the invitation to talk with you today.
Thank you very much.